Thanks.
Right. That's close to where
We've
they are.
actually for a little while now been recording all of our grand rounds. We just, Jeff didn't realize they were in the cloud under my account, so we're gonna work on finding a way to post them, but this one especially, I know many of us will be coming back to watch as we go forward, so especially for everybody who's not able to be here today, it'll be nice to have it recorded and we'll get it uploaded somewhere soon.
That's great. Thanks so much.
Yeah.
Well, that's a lot of pressure. Welcome, Dr. Abdalla, to give us the most anticipated grand rounds of the year.
Mm-hmm. And it'll keep on giving by record.
That's
Had it
true.
recorded.
Good evening, guys. So we'll start with a quick CRT basics, and then we'll look into troubleshooting for the fellows, and we'll talk about the GW CRRT protocol. So basically, regional citrate anticoagulation. So there are two ways of doing renal replacement therapy through dialysis, basically, which is concentration gradients and basically exposing those solutes, exposing the blood to the dialysate and making those solutes go through with concentration gradient. So this is what we call dialysis diffusion. And the second one is convection, which is when we refer to hemofiltration. So when we refer to hemodialysis, that's the first version. The second version is hemofiltration, which is basically getting the blood on the other side in the semi-permeable membrane and having a negative pressure on the other side, applying hydrostatic pressure on the blood side, getting those solutes drag all the elements with them with water. So basically water goes and drags whatever composition that the blood has in it. So these are the two ways: hemofiltration, hemodialysis. So we'll do actually for the citrate, we're going to do CVHD. So we're going to stick with one flavor. Everything's going to be standardized, so we're not going back and forth. CVHD, which is continuous venous hemodialysis, and basically we call it this vein, but the nurses will call it the arterial line, the arterial side of the circuit. We call it the axis line or arterial, though it's a vein. And basically your dialysis goes in against your blood and you get the ultrafiltration with that hydrostatic pressure and you get the dialysate out. Your citrate will go in as proximal to the patient as possible to get that anticoagulation.
Mhm.
So this continuous venous hemofiltration, basically instead of running dialysate, we give therapy fluid here. We do not do that often here, but this is something that you can do as well. And if you mix the two flavors, you can call it continuous venous hemodiafiltration. So it's if you do both at the same time. Our machines next stage cannot do that with the 3 pumps. You need 5 pumps to be able to do this. So something like Prismaflex. Effluent fluid is important. Basically, effluent fluid is the urine that you see on the other side. So it will be equal to your replacement fluid if you're doing hemofiltration or dialysate fluid plus the UF. So effluent fluid means your clearance. So basically, the higher your effluent fluid, the higher the urine that artificially we're making, the higher your clearance. And for little molecules, small molecules like urea, potassium, those actually the concentration of the blood, by the end of that filter, the concentration of the blood will be equal to the concentration in the effluent fluid. So if you have 7 potassium in the blood, it's going to be 7 in the effluent fluid. So the more effluent you have, the more the clearance. And that's what we call sieving coefficient, meaning that this effluent fluid is fully saturated with whatever you exposed it to. So if you need more clearance, it's not going to be by increasing your blood concentration because your fluid already saturated. So you increase your effluent fluid to get better removal. And that gets us to that citrate as well, because it's small molecules. So when you do citrate, you're actually removing it with your fluid. So the higher you go on your effluent, you remove citrate when you have citrate toxicity, in case that happens. So these are these small molecules that we remove quickly, all of them sieving coefficient of 1 or below. So all these sodium, phosphorus, potassium, they always get it. It should be the CVH or CVHD on those patients with hyperkalemia. It doesn't matter. Both of them are okay. And your drugs actually are small molecules. But what determines drugs removal is the albumin. Albumin bound. So albumin bound is the key in removing drugs. But it's not all of them are small molecules, but a lot of them is albumin bound. That's why we can't remove them. Also, volume of distribution is another marker. Between large and small, there's metal molecules, which is myoglobin. So if you have someone who's rhabdo, hemofiltration is better at removing those bigger molecules. So that's show you that there's no difference between hemofiltration and hemodialysis. You're removing the small molecules. The only one is the metal molecules. It's actually better with convective clearance. So the dose when we prescribe dialysis in the ICU with CRT, it's all about the effluent rates. We usually say you'll see it on the screen: 2 liters, 3 liters, and we go by kilograms. The order they recommend is about 20 to 25, but to get to that, you really need higher than that, 25 to 30. And this is for maintenance. This is not for a patient whose lactate is going to high, their pH is 7. So if you see someone who's prescribing this lower rate and the patient is unstable pHs, tell them that we need a higher dose. And so if you talk about, for example, most time we do like the 100 kilo patient, you do 2 liters, probably around 2 liters. And that get you to a clearance of about 33 ml per case, like eGFR of 33, creatinine clearance. So the higher you go to effluent rate, the higher that your urea clearance, and that should also dictate your drug dosing. When it comes to drug dosing, it's important when you have CRT patients to check with the pharmacist as far as the kind. There are medications who are kidney secreted or kidney reabsorbed. Those has to be dosed appropriately, because if this is kidney secreted, then you will have a smaller dose. If this is kidney reabsorbed, which is not happening like fluconazole, then you need a higher dose. So filtration fraction is a concept that it's basically whatever goes in that filter. If you remove too much of it, you're going to make the blood concentrated, and that filter will clot. So the higher UF, the higher the clotting problem. So if you're having clotting problems, you better dial down UF as possible. The other thing is, if you're doing hemofiltration, a lot of those fluid will go through those small pores and will clog the pores. So it's important to look at the filtration fraction. It's actually, you will see it on the screen of the machine. You don't have to calculate it. There's a calculation for it, but you don't have to calculate. The moral side of the story is if you have a higher UF, your clotting will be higher. Sometimes I get asked that let's just do hemodialysis for this patient before. Yeah, before we send them to the floor, making sure that they are able to tolerate hemodialysis. It's a very valid request, but you moving from one replacement fluid to another one, which dictate losing time or losing the circuit and getting another person to do it. So it's a lot of cost with that. I sometimes recommend to just go higher on UF with the caveat that you may clot your circuit, so you have to get close to that patient. You can do up to 300, 400 UF an hour, and that's close enough to mimic hemodialysis if you want to do fluid removal. And if that patient tolerated for 3-4 hours, probably will tolerate just hemodialysis as much. But for this patient, you have to be cautious with clotting, which shouldn't be a problem because you're taking the patient off as long as you don't lose the blood. Okay, so troubleshooting. So this is when we round and nurses look at that as well. They look at the filter pressure, they look at transmembrane pressure, they look at the effluent pressure. And if they are high, they start thinking about this filter is about to clog and clot. So basically, there are a couple of pressure monitors that we have in the circuit. And really, they're very easy. So we have the access pressure, which is basically always should be negative, which is created by that pump that pulls the blood from the vein. So with the pump pulling, that should be negative. If it's positive, means that you are in the artery, not the vein. So if you have an access positive, it means that you put that cannula and not in the wrong place. So after that pump, that will be positive because you have the pump pushing. So that's your filter pressure. So before it negative, after it's going to be positive. And you have here the filter, and across the filter, that's what we call transmembrane pressure, which is basically those small holes that you push through to get your water and the solute through it. And that's your effluent, was basically that's what the urine that's coming out, that's your effluent, the yellow pressure. The pressure will have the yellow side. The pressure will be in this between positive because you have some positivity coming here, and some negative because you have a pump that's pulling and kicking this urine out. So if you have too much of negative pressure, it means that this pump is pulling too much and not getting enough from here. So there is a transmembrane pressure that's high. On the other side, this is the return pressure, which is always be positive because you're pushing the blood back. And if there is a problem with this being too much positive, it means it's either kinked. And the same thing, if it's too much negative, it's either kinked or your catheter is against the wall or malpositioned in a way that's causing you too much of negative axis of pressure or too much of positive return pressure. So this is the first thing I look when I see those patients. I look at the axis of pressure. Is it too much negative or the return pressure is too much positive? Then it's the catheter problem. It's a catheter. And that's what I want you to guys to always, because most of the time it's a catheter problem if there's clotting. Then it comes to the other things. So this is the clotting and clogging. Clogging, basically, these small holes, when you push through, when the water comes in, the solute in the hemofiltration, that's where it clog with the proteins and get closed. And in those patients, will have transmembrane pressure high, effluent pressure, we are pulling, but there's nothing coming out, so it's too much negative. In both situations, the filter pressure will be high. In the clotting, we look at the pressure drop, because you have a lot of clots here, so the pressure will drop too much on the other side here. So if we have high filter pressure or high filter pressure drop, we know this is clotting.
Why do you have negative fluid pressure? I thought it has to be positive.
Which one?
In
In the effluent, it's going to be in the effluent side.
yeah. So
The high negative
negative?
effluent, yes, because you are basically pulling. Yes, pulling from the circuit and it's clogged. It's clotted here, it's clogged. And you're trying to pull, but not much volume coming out. So you're creating more negative pressure.
Because you're no longer getting the positive.
because there's already fluid in the column.
Yes.
I said.
So in those situations, you have clogging issues. And the clogging is happening because you are doing a lot of hemofiltration. So if you get away from hemofiltration by adding a little bit of hemodialysis, either alone or combining both, you will lower the clogging issue. Citrate works for both for clogging and clotting. Increasing the replacement fluid is not going to be a good thing because you're pushing more volume through those small holes and the protein will clog more, clog the holes more. This is another patient where we have here filter pressure that's high and pressure drop that's high. This filter is going to clog. And in those patients, obviously you don't keep changing the filter every 24 hours, which is not far from our circuit life. And the pre-filter, increasing the pre-filter fluid, it does help at times if you're doing hemofiltration, but a problem if you're already at high dose, it may actually worsen things. So here citrate works the best. Increasing blood flow is not going to make a difference here. You're already at the maximal, not allowed, but maximally effective blood flow. More than this doesn't make any difference. So anticoagulation strategies, we either have systemic anticoagulation, which we do a lot of patients on, if they're already on it, like the ICU 2. There's the regional heparin and the regional citrate anticoagulations. So the regional, renal replacement therapy without actual anticoagulation, you end up delivering lower dose in about 30% of the patient because the short circuit life, increased downtime, and reduced filter performance. And also, those patients will have higher blood transfusions if you compare citrate versus no citrate CRRT. Systemic anticoagulation with problems with hemorrhagic complication from 5 to 30%. So the choice has to be regional anticoagulation. So with regional heparin anticoagulation, the dosing, you start with bolus and you maintain between 5 and 10 units per kilogram. And you run it obviously pre-filtered. If you are a patient, you have to use it, and it's about risk and benefit, and there's a risk of bleed. Try to avoid not to bolus. We do not bolus those. We just start with the 5 to 10 units. And the goal of checking ABTT is not to reach the goal, but actually not to exceed, because when you go above 45, the risk of bleeding it goes higher. So since 2012, actually, KDU recommend doing citrate as part of standard care for CRRT. So-
Just a couple years late.
Yes, that keeps. So regional citrate anticoagulation, basically it's like, since human knew how to preserve blood, they use the citrate to actually chelate the ionized calcium, which is, as you know, it's all needed throughout the coagulation cascade there. The half-life is about 5 minutes, predominantly by mitochondria in the liver, muscles, and the kidney. And for every 1 millimole of citrate, we get 3 millimoles of bicarbonate generated. So the post-filter ionized calcium, the goal should be between 0.25 to 0.35. And to maintain the calcium in the blood, that's the goal of systemic ionized calcium to be between 1.05 to 1.25. So we are running calcium replacement as we're doing that. So there's a risk of citrate accumulation, which is, it goes from 0 to 12, and this is all based on your protocol and the team that practicing that. The risk is higher with severe liver failure or rising lactate shock state. So if you have whatever shock state you have, if your lactate is rising and LFT is going south, it's not the right patient for citrate. And it doesn't have to, it's not like a permanent thing. As the patient turn around and start getting better, then you can initiate the citrate, but this is not the right moment to start in those patients. So if you have impaired citrate metabolism, basically you will end up having lower bicarb, and that will have metabolic acidosis. And the concern is always is to get to a state where you have actually citrate toxicity. And as things to look at is the ionized calcium that's getting lower despite you're giving more and more calcium gluconate, and that your total calcium is actually getting higher because you have calcium citrate that's staying in there. So the total calcium is going to be high. Ionized calcium is going to be low despite increasing your calcium infusion rate. That's a red flag we should pick. There's a ratio actually we have at Cerner. Thank you to the IT folks. They already have the calculation there. So it will show you, you don't have to calculate it. For the fellows, they have to calculate it. For the critical care nephrology fellows, they have to calculate that.
So it's the calcium gap, basically?
Yes.
Okay.
2.8,
Yeah.
the ratio is more than
Ratio,
2,
yeah.
yes. 2.5, that's risky. It means that you're actually.
Greater than
Yes,
2.5.
yes.
Okay, got it.
So complications, hypernatremia, not very often. Calcium and magnesium, because you are removing all these. And so basically we check those every day. We replace those. Metabolic alkalosis, not a high of a concern, but if you see it, it means that you're overdoing it. So, or the patient's getting blood product that has citrate in them. So you should dial down. If you're really concerned, then you can increase the dialysate to wash out the citrate. Most of the time you should be fine with that. You're just dialing down would be okay. This is the next stage. So we have to choose, have to think and choose the most, how to say it, we try not to buy a lot of fluid. We have tried to be cost effective. So we choose those fluid that has 4 potassium. Okay, so a patient who have high potassium is not the best one to start with if you want to correct quickly. But if the patient is like potassium 6 or something, you can manage with this. But if the patient is very high potassium and you're trying to correct things quickly, you may start with non-citrate and then switch to citrate. So you have the potassium is 4, but obviously.
All of the citrate has fixed potassium.
All of it. So it's got, okay, one
Okay, so
bag.
you can't, oh, there's no different bag.
There's no bags. There's only one bag. It's 0 calcium, 4 potassium.
and you wouldn't mix bags, because
No.
there wouldn't be enough citrate.
So if you mix bags, one of those bags is gonna,
Have
those
calcium.
that have calcium, so you will be required a factor of citrate.
Yeah.
Yeah. So bear in mind, and I think this is okay, because most of those patients who are having big time things, you probably better starting with non-citrate and then switching to, in 24 hours, it's time to switch to citrate, and 4K should do just fine.
So are we gonna know that we switched, for example? Is there gonna be a flag that we know the patient's being dialyzed or the?
Citrate, yes, absolutely, yes. So metabolic acidosis, so if you have acidosis, you think am I doing not enough buffer, or there's citrate toxicity? There's always the nightmare is citrate toxicity. That should be the first one. Always you have to rule it out before you start going up on your citrate. If we think, no, there's no citrate toxicity, we looked at the ratio, we looked at everything, looks okay, then you can just increase your buffer, increase your citrate. After ruling out, you just.
You're increasing that fluid that has the citrate in it. but on the
Correct.
buffer.
Yes. So after ruling out, you can just increase your citrate delivery by increasing your citrate infusion rate.
Sure.
Impaired citrate metabolism, as we said, accumulates citrate, and that's the toxicity risk. We talked about liver failure, shock state. Look for worsening and metabolic acidosis, metabolic acidosis, increasing calcium infusions, falling ionized calcium, increasing the total calcium as we talk about, and the ratio above 2.5. And you start having hypertension, cardiac arrhythmia, and that hopefully we don't get there.
You said that's in the system. right?
Yes, it's gonna be under that. So it's gonna be next to each other, the filter. So there will be systemic ionized calcium, and there will be the post-filter ionized calcium, and there will be the ratio. It's gonna be all next to the CVS. So there's increased citrate toxicity. Obviously, if you have mitochondrial inhibitors like ethylene glycol that have inherited acquired mitochondrial cytopathies or some of HIV meds, as long as you are watching, it's not gonna happen. And I don't think ethylene glycol anyway. You need real hemodialysis, not real. You need intricate hemodialysis or aggressive hemodialysis for those patients. What do you do when you see a sign of citrate accumulation? Basically, you have to reduce your citrate infusions. If that did not do the job, you can increase your dialysate, which basically will wash out the citrate. As we said, citrate is a small molecule. You can wash it out quickly. If there's a high concern of citrate toxicity, you have to abort the process. So switch to citrate to non-citrate base. You stop the citrate and calcium gluconate drips and switch to dialysate to calcium containing dialysate. Use higher effluent rate for clearance of the citrate and also correction of the acidosis. So you do both at the same time. And you obviously need to replete the calcium as you go. If you have refractory ionized hypocalcemia, you have systemic ionized hypocalcemia, that's refractory. Look for signs of citrate accumulation. This is the message there. Vascular access reserve, if by mistake somebody shake the ionized calcium from the circuit, then there might be a recirc, because even you checking it before the citrate infusion, you think that you're checking it, but those holes of the catheter, they're next to each other, so you can have recirc there. So ionized calcium should not be drawn from the circuit, and the nurses understands that as part of their.
When you're giving the IV calcium back, can you give that in the side port of the dialysis catheter? Or is it gonna mix with the citrate?
So giving the ionized calcium back, you can
Yeah,
do
no, I'm giving calcium chloride,
Yes.
the infusion that you're giving.
of the calcium
Trialysis, the pigtail, you mean?
Yeah,
infusion of
the
the,
infusion of the calcium that you
yes,
give
yes,
post dialysis.
yes.
Can you give that through the pigtail of the dialysis catheter, or is that gonna mix with the citrate that's going in?
So you
But
can.
you wanted to mix with it, right? You don't want to.
No, this is the
no.
calcium you're returning.
Yes.
You've already chelated all the calcium.
Yes, yes, so that might be a risk for recirc as well, if you do so. You do.
So where do we put the IV calcium? Because this is calcium chloride, right?
Yes, you calcium gluconate, calcium
You
gluconate.
can do that,
Yeah,
okay,
calcium is peripherally, you can do it peripherally.
okay.
Yeah, it's.
So this person's gonna need like a midline, likely. You can't just have your dialysis catheter, it's your only access.
And you can
Your
do it,
trialysis.
it's mixed in a way, it can be done preferably. So if you have a good peripheral line, you can do it.
You cannot use fluorides.
We have everything set up as calcium gluconate already
Okay.
mixed by the pharmacy, and the order is there. So everything is in one set format.
Okay.
Yes.
So if you
But just the-
connect to the same site in the same IJ, it's going to recirculate and it's going to chelate,
It's
recitrate.
gonna, it'll chelate the calcium you're giving back, and so you're potentially gonna be hypocalcemic.
So if you give it back, you might be taking more of it. Okay, and that's not a
Right,
big,
well,
but it's not a big deal. It's not a big deal for me. It is because it will require just more citrate.
Okay,
The bigger deal is if you think that there is a ionized calcium, that's, if you think there's hypocalcemia, and you basically checking your calcium from the circuit. So
Mhm.
calcium should not be checked from the circuit, ionized calcium. So if you're checking it from the arterial line, what's called the axis line, the arterial, and you're thinking, I'm checking it prior to giving citrate.
mhm,
But with that, there's a risk maybe recirculating there,
mhm,
and that calcium is low. So this is a big no.
got it.
Giving the calcium back, if there's no access, I think it's not the end of the world. It's just gonna require, if you're having issues with more citrate, that would be the reason that maybe you're picking up. But safety wise, this would be a safety concern
Okay.
if you, how do, so if you
I'm
have.
not looking at an accurate calcium.
Yeah.
Yeah, okay.
So then you
So,
would have to have a peripheral.
so you can get it from the airline, you can, the patients in all these patients have airlines, so so for now, we told the nurses to get your ionized calcium from the airline. So
Okay,
nobody get confused.
And it used to only be ice that we get the iCal, but the lab does it now?
the lab does it.
It's ionized.
It's
Yeah,
ionized on the lab and not on the ice. We don't have many on the ice, that's all.
but the lab.
The lab is on
Like
the
the same
team,
day.
yes, on the 30, less than 30
No,
minutes,
every 60, you'll go through the program.
yes,
But yeah, it'll come back.
Not-
within 30 minutes. They on the call,
Alright.
yes, they saw it.
Cool.
It's gonna happen within 30 minutes. So a special consideration, it's not a big deal, but try not to be aggressive in replacing potassium and calcium in those situations, because basically, when this resolves, that calcium will go back to the circuit, to the body and the blood, and when your metabolic acid alkalosis resolves, that that citrated calcium citrate will unbound, and you have ionized calcium that's going to go higher. When you have a rhabdo and things settle down after the first peak, or you have pancreatitis and post-tumor lysis, after things peaks or after the hypocalcemia phase, you will start having the hypercalcemia phase. So for those patients, try to not to be aggressive in replacing potassium, calcium. So have to be, otherwise you will induce iatrogenic hypercalcemia. It's not the end of the world. The patient is in dialysis, we can remove that, but better not to do it. There will be calories in this. So this is like between 350 to 600 kilocalories. And so this has calories in it. So nutritionist has to be aware of this. The GW protocol. So this is, the nurse has been indicated twice actually on this. The citrate and calcium infusion must be turned off or on at the same time. Everything has to, it either goes all or none. There's no one should go and the other one do not go. So changing the flow, the blood flow rate and dialysis flow rate is not allowed, even by the nephrology fellow, without talking to that attending. This is not, because going up on one is gonna mess up the whole calculation. And there is a problem with the, not a problem, but there's, we have to be concerned about UF. And actually in the order set. So, because we're adding 70 ml of calcium gluconate and 170 ml of citrate, that's going on. And because the machine are smart, they do not recognize that. So we have to put a UF at 240 an hour. If you want to
Just to
give,
make it even.
to make it even,
Okay.
if you want that 240 to go, you're aware of it, then as an intensivist, you should say, okay, I know that I'm giving 240 ml an hour. But with the citrate and the calcium, they're going 240 ml an hour.
So
So
it's like a fixed rate.
that's a fixed
So
rate.
that's when you said 240 now.
Yes,
Okay.
so that's that, the UF is set up at 240. The nurse has to put a UF at 240. That's your net either, okay? That's gonna be in the order, unless you change it, okay?
So if we're trying to get 200, you're gonna be at 440. If you want 200 off an hour.
Yes,
You're gonna
it's
set it
gonna
at
be,
440.
yes,
Okay.
yes. So contraindication, these are, the nurses will not let you do it unless they look at those, make sure that the ionized calcium is not below 0.85. If it's around one, they can, if it's above 0.85, it's not up to 1, you can give 2 calcium gluconate. They have protocol for that. LFT, if they are rapidly worsening, or they're rising, lactate of 7 or rapidly worsening. If you have like lactate of 4 and patient with 3 pressors, you don't have to wait for lactate to go 7. This is not a patient of citrate. So if you have already hemodynamically unstable patient that's going in a progressive shock, then this is not the patient for citrate. Wait until things settle down, then you can introduce citrate.
What about non-lactate acidosis?
That's fine. It should be okay. So this is the protocol for the nurses. They have to take 2 of them. They have to make sure they do everything based on the protocol. And this is the order set. This is in Cerner. It's just gonna go like this. The fellow is just gonna click it, and the blood flow is fixed at 100, the citrate at 170, 70 ml per hour, the calcium gluconate, and 2 liters of dialysate. And the ultrafiltration is gonna be 240 ml an hour.
Need to go back and look at this. 1.4 calcium an hour.
Is the blood flow rate low?
What's that?
The blood flow rate?
It is very low.
That's.
You know why? Try to save some
Because
money. The higher the blood flow, the higher
The more citrate you're
Citrate you need.
gonna need, because you filter out the citrate.
you're chelating it with citrate. So the more the blood, the more the citrate.
So again, if you have a patient with a super high lactate, this is not only is it dangerous, but it's not gonna work well.
Yes,
They're taking too
absolutely.
long.
Yes, yes. So that's why it's not an
And
option.
then the citrate will, because right, those rates, the citrate will prevent it from clotting.
Yes, so we should be fine with this.
That can be
Yeah.
done.
So this is like the chronic lady who's on CVVH for days and days and keeps clotting. But like,
Yes.
sort of stable, but you need fluid off, that's
Yeah.
that person.
I think we try to introduce it even for those folks who's should be more of a standard, but for those hemodynamically stable,
Stable, yeah.
not, yes.
That's
So
just starting.
yes, so to improve the also,
The
the
sort of
longevity-
longevity of
yes.
this.
yes.
I feel like the sick people are the people that clot most often.
Yeah.
Well, in the first 12 hours, you know how things is, you don't want to add risk more to the rest of
Yeah,
your lives.
yeah, yeah.
Yes, yeah.
We'll just blame it on the catheter.
That's what we do.
So these are guidelines you have to
Correct.
remember. It's gonna be, it's in Cerner, the nurses are looking at it, they have to actually print it and they have it in Cerner there. And they're gonna check at the ionized calcium, make sure that it's the post-filter one between 0.25 and then 0.35. And if they make the changes by going up on the citrate, and they did not achieve the goal after 2 changes, they have to reach out to the MD to make call. There's hard stop at 120 and 220 of citrate. They cannot go up above that or below that. And same thing for ionized calcium. They have their protocol to follow and based on the ionized calcium. So the goal is to keep it between 1.05 and 1.25. And if there's any changes, they have their own protocol to follow. And after 2 changes, they have to call the team.
And are they calling us or are they calling the nephrology fellow or both? Like,
They should call both, but nephrology fellow for sure. They we should have a call about this. Yes.
Is there a role for supplementing calcium enterically? Or is it all IV?
I think IV is the way to
Two
go.
classes.
Yes.
You don't know what their approach.
So these are the labs. We made it as simple as we can. So your ionized calcium is 1 hour before and 1 hour after start. Or whenever you change or resume things, after you stop, after that, it's every 8 hours. So it's basically the same way that we do now. So every 8 hours is labs here. Okay, post filter is only in the first 24 hours. Ionized calcium 1 hour after, and then every 8 hours. Most of the time within 24 hours, you should be achieving goal. And after that, we're doing it every morning. It's only every morning. We don't do it that often to confuse things. So every morning after the first 24 hours.
So, sorry, are you doing systemic and post filter to compare?
Correct.
Okay,
So
got it.
every time you do post filter, you have to pair it with ionized calcium. So you have to interpret right. So every time if you want to do one, you should do the whole set. If you are concerned about you're not achieving, if the filter is clotting. Okay, that's the time when you check post filter. The filter, despite all this, the filter clotting, then you should check post filter. But with that, you should also check ionized calcium and you check BMB to have an understanding of the situation.
Is this something in the generic order sheet or sodas, or is this the nephrology is gonna order?
Yes, it's the order set. The
We
nephrology,
just know it's happening.
yes, it is happening. And so the nephrology fellow, it's all attached in one favorite order. And they click one click and that all comes together.
Sorry, I don't mean to be an idiot about this, but why do you have to, remind me why you have to check the post filter one? Is it-
So that's what you need to achieve your goal of post filter anticoagulation.
So that's what- for the 0.25,
Yes,
6.35, to make sure you've chelated enough.
correct.
Got it. And then the systemic is just to make sure you have actually gotten enough calcium back into the system and
Absolutely.
you don't have a big gap.
Yes,
Okay,
yes.
got it. Okay.
And in the post filter, we try to minimize checking it as possible. As long as your circuit is going, you don't have to check the post filter more than once a day. So we do it only in the morning.
Okay.
If you're having issues during the day, then yes, you may want to check it, but with consultation with nephrology and checking at the same time, the ionized calcium, making sure you're not making decisions, increasing your citrate and your ionized calcium is going south. So BMB is every 8 hours and daily mag and pause. Liver function test and INR daily, one prior to start, just to make sure that we know the situation, and same for lactate. We need lactate daily and one prior to starting. So this is the labs, and it's gonna be in order. So every time that you change, anything, patient goes disconnected, we start from scratch, start from the beginning. You go back to the same infusions, but the lab should be done as a start. You go back to the same rate of calcium gluconate, same rate of citrate, and just you do once and just to make sure that you're back. So this is gonna be only weekdays, 8 to 4. And as this is for staff availability, so build experience and to watch for if there's any concern about contraindication or risk of, to predict the risk of regional citrate anticoagulation. So we'll start, this is talking about initiation. If your patient is already in it, then already in it, but for initiation, we're gonna start with this. Okay, so this is information we, as a fellow, we have to gather when we have a concern about citrate problems. Any clinical changes, the site is important. Where those labs has been drawn is important. I want you to ask the nurse where the citrate is going, where the calcium. Don't assume things. Sometimes it's where the citrate going, what the drip changes, the calcium, where is it going with the changes, and the pressures if changes. And the same, you get all these, the calcium, ionized, post filter, adding gap, bicarb, lactate, and CNV, and then you report this. So this is an example, a nurse calling in with patient is hypotensive and has some cardiac arrhythmias. EKG is showing concern for anterior wall MI, and there is ST segment depression in the inferior wall, inferior leads and prolonged QT. Basically, hypocalcemia, it looks like is happening there. And you ask about the side and the drip and the trend, they tell you the citrate, we were going up, we reached 260, okay, instead of 170. And the calcium drip is now 150, doubles like from 70 to 150, and pressure is going south from 2 to 10. And your calcium ratio, you look at it, more than 2.5. And the ionized calcium, despite all this 150 an hour, is 0.7. And your post filter is doing well, for less than 0.25, it's actually way lower than what we should. And the adding gap is worsening, bicarb is worsening, lactate is worsening, so this obviously, this is citrate toxicity, this is the citrate toxicity we talked about. And that's it.
You know what, I'm glad we did this the second time around, because now I get it.
Okay.